Hello, my name is Richardson, and today we'll be discussing my research topic and article, Hourly Rounding Replication Study. The purpose of the study was to see the effectiveness of hourly rounding and to assess the impact that it had on falls, call-out usage, and patient satisfaction. There were 3 previous studies done on hourly rounding. 2 were successful. 1 was not evaluated because of lack of data and information for the study design. The problem we have is that there's less rounding for patients. Rounding in the mid-20th century was a normal idea, a normal practice, until the nursing shortage hit and there was less nurses and more patients. This affected nurses taking care of patients properly, which led to increase in falls, decrease in patient satisfaction, and patients utilizing the call light button as much as possible. We can make many improvements if we implement hourly rounding into our teaching in the hospital. The significance to nursing would help nurses manage their time better instead of running around trying to distribute meds to all the patients as fast as they can. This would increase patient satisfaction because the nurse and the patient would have more of a bonding and respectful relationship. And it would also build the nurse-patient relationship as well. And overall, this would make the patient care very high and quality would be great. The variables were patient falls, call-out usage, and patient satisfaction. The study design was a replication of the Mead and co-author study from 2006. It was a quasi-experimental study, which means that they cannot control everything that happened in the study. Interventions and treatments were not utilized, and they used 2 floors that were med-surg. The 2 floors that were med-surg met the inclusion criteria, which they were roughly the same size, had a high number of falls, and they had roughly the same amount of post-operative and medical patients. There were 2 clinical nurse specialists that ran the study. They implemented teaching to all RNs and unlicensed assistive personnel 2 weeks prior to implementing hourly rounding for the study. They also taught the float RNs and unlicensed assistive personnel the training for hourly rounding as well. They were constant on those floors. The hourly rounding went from 6 a.m. to 10 p.m. When the nurse went in, they asked the patient if they were okay, assessed pain, position, and if they needed to go to the restroom. Once it was finished, they would exit the room and log that on the chart outside of the room. From 10 p.m. to 6 a.m., they did 2-hour rounding for environmental checks. They would check to make sure the breaks were on the bed. They would check IV issues, medications, if the patients were hungry. After that was done, they would log that as well outside of the room. They would also log what call light pressing was for the bathroom, for comfort, for food, medication, etc. 4 months into the study, they held refresher training for all RNs, unlicensed assistive personnel, and float RNs and float unassisted licensed personnel. In the beginning, the falls were 3.37 per 1,000 patient days, and in the end, the falls went down to 2.6 per 1,000 patient days, which was a reduction by 23% in falls on the experimental floor. The control floor had an increase in falls. The call light portion was compromised, which we'll discuss in the next slide. Patient satisfaction was not significant, but RNs said that patients showed satisfaction increasing by verbally stating that. The sample size for limitations was recommended that they used the larger group of people. It was non-randomized, and with the call light incident, there was the delirium patient who pressed the call light button 186 times in 6 days. The patient did not need the nurses, he just kept pushing the buttons. They needed to train new nurses and new unlicensed personnel to continue with hourly rounding, and also reinforce positively reports from falls and call-out usage promptly. The first report for any of the nurses for hourly rounding was not delivered until 4 months into the study. There was also issue with supports through all 3 shifts, which brought down the hourly rounding charting. There's promising nursing effects for hourly rounding. As long as we do hourly rounding, patient falls will decrease, satisfaction will increase, and call-out usage will decrease because we're seeing the patients every hour. It would be recommended that it's implemented hospital-wide so everybody's trained in hourly rounding, which will also assist in the study as well. The potential is there. We just need to achieve it by learning how to do hourly rounding and look more into the research for that. Future studies suggest that we need to focus on correlations between patient complications and whether or not they are decreased with hourly rounding. In conclusion, satisfaction is key for the patients, and that's big for us because with hourly rounding, it'll help us take care of the patients as best as we can. We continue the hourly rounding, which will be helpful to teach new nurses and to take care of patients properly. This will also help us with patient safety because we are decreasing patient falls and call-out usage, which means that we're taking care of our patients properly. And overall, the hospital's reputation will boost because nurses are taking care of the patients properly, and we are giving the best quality care that we can. And that's all for my presentation.